Good evening, friends. Welcome back on behalf of IJH Homeopathic Journal India Foundation. I hope you all have downloaded our journals. Hmm? And today's topic is warning signs in different monsoon fevers. And our speaker is Dr. C H Asrani, sir. Our most of the seminars starts with sir's clinical topic. And I remember our seminar was on headache. And that time I used to suffer a lot of headaches and I had been to various doctors. And sir said, if you have progressive glasses, you should wear your glass 24/7, except two times like bathing and sleeping you have to remove, which I was not aware. And I said, sir, is it? We have to wear so much time. He said, yes, you have to. And he asked me, where is your specs? Is it in your bag or is it your home? And after that, considerably my headaches have gone down. So many times this type of things are very important in our practice, like ophthalmologist, neurologist, no one could tell me that. And I was suffering. So now monsoon is increasing, fever cases are going up. And this time, if you see, fever is coming up with lot of weakness. So what we'll do? Are we going to do investigation on day one or we are going to observe for some time? You'll get answers for various such questions. So little bit I'll tell about Dr. Asrani sir. Sir is MBBS DNB and he has active clinical practice last 40 years. And over 2 decades, he has experience in insurance consulting. He's founder of Inches Academy and conducts workshops for practicing doctors and insurance professionals. He has conducted over 500 seminars and 50 plus talks for homeopaths. He has been training across Dubai, Singapore, Bangkok, Malaysia. And very important that sir knows 6 languages and very effectively he communicates with people with these languages. So sir, I welcome you and enlighten us with the topic warning signs in different monsoon fever, a very important topic for the current days.
Thank you, Dr. Nirupama. Welcome, dear participants. Before I start talking, let me make a formal announcement. Today we are on 19th of July. 16th of July 2023 was the foundation of Homeopathic Journal India Foundation, when Dr. Vishpala, in a meeting where all 25 of us were present, suggested that we launch a foundation to continue her legacy of NJH, and we did that. So here is promising you that every year 16th July will be celebrated as our foundation day. Now, why have I chosen this topic, warning sign? Do I want to scare people? No. I want you to be a good practitioner. In the first Sarla Sonawala Memorial Seminar in Bombay in 1995, we had called a pediatrician of repute, Dr. Amdekar, and he had said, before a child leaves your clinic, ask yourself, can this child die in my hands in next 24 hours? I have been practicing that. And what I feel that no doctor, allopath, homeopath, Ayurvedic, should ever face a time When a patient comes and tells him, the family comes and tells him, सर आपको मालूम नहीं पड़ा कि ये critical था? When you miss out sending to the hospital, when you miss out sending for referral, when you miss out sending for investigation, nobody should come and tell you, sir, did you not know that this was critical? And for that, for you to get the right remedy for your treatment, you must have good amount of clinical acumen. And clinical acumen apart, you should always know where to stop, where to pause, take a second thought, maybe change the remedy, or maybe refer because you are seeing a sign that worries you. As a doctor, if you get worried, no, then that is the thing that now it is to be referred. So I will start my talk. Warning signs in different monsoon fevers. By the end of the talk, you'll realize that all the signs are similar, whatever the cause of fever may be. Hospitalization in acute condition or fevers, that means when you will refer. Dengue is one condition where we have to understand the warning sign. In 2023, India officially recorded nearly 95,000 cases and 91 deaths by 17 September 23. And it's only recorded cases, reported cases. I don't know how many of you report to the municipal authority of a dengue malaria that you detect. Then we have malaria, we have leptospirosis, we have meningitis, we have pneumonia, we have urinary tract infection, acute gastroenteritis, typhoid, and chikungunya. Each one of them presents with fever and supporting symptoms. Who's more at a risk of worsening? You see every patient. Number one, who has low body reserve, children below 5, elderly above 70, and those who have one chronic illness in their body plus infection is a sign of danger. A patient of dengue with platelets at 60,000 was admitted because hemoglobin kept dropping and the X-ray showed bilateral pneumonia. Her fever had gone. She was immunocompromised because she was uncontrolled diabetic. Patient with any autoimmune disorder or patient on long-term oral steroids, not inhaled. Chronic renal failure with without dialysis, cirrhosis of liver, uncontrolled diabetes mellitus. Patient on cancer chemotherapy, again this long-term oral steroids are repeating, sorry. COPD, chronic obstructive pulmonary disease, tuberculosis, hepatitis B, hepatitis C, HIV. So hepatitis B or C gets hepatitis A, our conventional jaundice, this patient can die. A tuberculosis patients get pneumonia. A diabetic patients get UTI. These are the patients you have to look for very closely. How do people become more sick and how do they die? Death rate from all the fevers that I listed is merely 2 to 3%. But then that is, my dear friends, preventable. So complications or morbidity or death may occur by dehydration, electrolyte imbalance. 90% water of a 3-month-old child, 90% body weight of a 3-month-old child is water. One large loose motion, one large vomit can kill them. Hypoxia, we all became conscious of hypoxia in COVID. ARDS, acute respiratory distress syndrome, which requires a ventilator or a BiPAP. Metabolic acidosis, patients who are having a compromised system, commonest uncontrolled diabetes, with any infection, they get metabolic acidosis. Thrombocytopenia, low platelets leading to bleeding. Acute renal failure. Kidneys may be normal or kidneys may already be having chronic renal failure. Acute renal failure is reversible, but acute on chronic renal failure is almost death. And direct catastrophic effect of the disease, dengue, hemorrhagic fever, or cerebral malaria, they kill directly. So all of these are common in all the fevers that we have listed. This, as per Government of India guidelines, are warning signs in dengue. Respiratory distress leading to ARDS, oxygen desaturation leading to low oxygen, severe abdominal pain, excessive vomiting. Why should a dengue patient get abdominal pain? Indicates he or she may be bleeding inside. Excessive vomiting or uncontrolled vomiting, altered sensorium. A patient is drowsy, a patient is not responsive. Fever and altered sensorium is a red alert sign that refer. Convulsions and fever in an adult, very grave sign. Rapid and 3D pulse, tachycardia and low volume. Narrowing of pulse pressure less than 20 millimeter of mercury. Difference between systolic and diastolic. The pressure normally is 120/80, that is 40. 130/80 is 50. 40/50 is amazing. Below 30 is a matter of concern. And below 20, you have a systolic of 120 and you have diastolic of 102. Very critical. Urine output less than half ml per kilogram per hour or less than half a liter in a day is almost anuria. Laboratory evidence of thrombocytopenia, low platelets, coagulopathy, patient bleeding somewhere, rising hematocrit. What does it indicate? Hemoglobin going up. 3 times of that is hematocrit or PCV. That shows hemo concentration. Hemo concentration, especially in dengue, is very bad. Metabolic acidosis, liver or kidney function deranged. This, my friends, is a list in any fever, whether diagnosed or not. If you're getting these, you have to become very alert. Warning signs in all fevers. So there are certain organs in our body which we call as target organs because they are required for our body's survival. Lungs, when affected, lead to acute respiratory distress syndrome. Kidneys, when affected, lead to acute renal failure. Brain, if affected, leads to encephalopathy, altered sensorium. Liver, if affected, leads to coagulopathy because all the clotting factors are made in the liver. And then patient bleeds because they cannot clot. And if heart is affected, it is known as cardiovascular shock. This patient's heart is not pumping enough to maintain the BP to 120/80. They require medicines to make the heart pump better. And in certain cases, if the patient is immunocompromised, some major disease already present, more than 2 of these organs fail, it is called multi-organ dysfunction syndrome. I'll show you later on, and that leads to death. Coming to hypoxia, generalized hypoxia, body deprived of adequate oxygen supply. Below 80% oxygen needs hospitalization. Make sure oxygen is measured correctly. Take the middle finger, massage it gently, and then put the pulse oximeter. In COVID time, we used to get frantic calls at 6 in the morning. Doctor, oxygen is 65. I just woke up and applied the pulse oximeter. No, you have to re-establish the circulation. And if you have below 80, straight referral, no attempted heroics. All clinics must have a good pulse oximeter. Metabolic acidosis in severe conditions affects the lung, kidney, and liver and leads to metabolic acidosis. In a diabetic infection, metabolic acidosis known as diabetic ketoacidosis. So how do you determine whether this patient is getting into severe infection and likely to go into complication? Pulse rate. Now I'm giving tips about adults and children both. Those of you want can take snapshots of the slides. Best measured when the child is calm, adult is resting. Measure the radial pulse at the wrist for 30 seconds and multiply by 2. In babies under 6 months old, brachial and femoral pulse may be easier to feel. Why I'm saying this? Because a lot of homeopaths start treating infants and neonates. So there you don't try to do radial, you do femoral or brachial. This is a chart of pulse rates of different age groups. If you see by adolescent, it is reaching the adult rate of 60 to 100. Pulse rate of a child who is sleeping may be 10% lower than the lowest rate listed. Capillary refill time, a very important test to assess the circulation indirectly. It shows if a patient, whether adult or child, has a compromised circulation. Compromised circulation means what happens, The body needs blood. So the blood from periphery rushes to the core, the center. And this is called compromised circulation. We are checking if the body has constricted the blood vessels in the periphery in order to preserve the more important central circulation, cardiac circulation. The common conditions are serious bacterial sepsis or moderate or severe dehydration. Very useful in children, since BP does not drop until the child is extremely ill, even if checked. Not many of us are equipped to check blood pressure in a child. And a tachycardia in children is not as reliable a sign as adults because children normally have tachycardia. Use concurrently with mucous membrane color as an indirect measurement of peripheral tissue perfusion. Normal capillary refill time, CRT, is 1 to 2 seconds in children and up to 3 seconds in adults. This is consistent with a normal blood volume and perfusion. A CRT longer than 2-3 seconds is a subjective sign of poor circulation. You can be certain that this child has compromised circulation, and I must admit. How do you check? To measure, we should press for 5 seconds, remove the thumb, and then count how long it takes for the white area to refill with the pink color. Again, I said 2 to 3 seconds. 5 seconds can mean that urgent resuscitation is required. How do you see? This is how you do. You first press for 5 seconds, it blanches. It should become pink in less than 3 seconds. This is circulation. Now we come to the airway. Count the respiratory rate for 30 seconds, not looking at the chest. The patient, child or adult should not become conscious that you are counting the breathing. So you may act as if you are holding the hand and you're counting pulse. Look at the navel, but your eyes are watching the chest. Respiratory distress is indicated by flaring of LNSI and recession of intercostal spaces. Best done when the child is calm, as crying or coughing can alter the rate considerably. This is for those of you who have a good pediatric practice. Normal range varies with the age of the child. Assessment of airway. This is the rate of different age groups. You see, adolescent is reaching the adult thing of 14 to 16. Looking at the reception of intercostal spaces, that means that every patient must be disrobed. If you are worried, adult or children, females, you may have to treat them with respect and decency. Mild, no sternal intercostal recession at rest. Moderate sternal recession at rest. Patient is neither agitated nor lethargic. Severe sternal as well as intercostal recession associated with agitation lethargy. What does agitation lethargy tell me? That the oxygen is not enough. If in a child, this child can die within hours. So those of you who love to treat online, on phone, how's the child? How much percentage better? Please insist fever should be brought to the clinic. Heart rate, tachycardia, bradycardia in a critically ill child is ominous. Children have higher pulse rate than adults. So child is bradycardic, it is ominous. In adults, does the pulse rate correspond to the fever? Normally, pulse rate rises with fever. So a person with 103 fever may have a pulse rate of 120. I'll accept it, but 140, no, sir, I will be worried. Is the patient a known case of hypertension or a heart disease on treatment? Pulse should be checked central as well as peripheral. Sorry. Is it present or absent? What is the volume? Is it good volume or is it 3D? I'm sorry, I'll just take a lozenges. Sorry for the interruption. Pulse pressure, as I said, systolic minus diastolic. More than 40 is a warning. Less than or 1/4 or less of systolic is improper heart pumping. Best measured when the child is calm and adult is resting. We have said this already. This slide is duplicate, I'm sorry. Blood pressure. How many of you have multiple cuffs? How many of you can actually check BP of a child if required? Although, if you do not check up, it's not a crime. But at times, it is better to have 2-3 cuffs. Cuff should cover 2/3 of the arm, adult or child. This is the blood pressure of children. You see, after 12 years, it is virtually coming to adult. Can be difficult to measure in children or obese individuals. So at least if you have one machine for adults, have two cuffs, one Velcro and one non-Velcro. Because obese patients or people with huge arms, you cannot check with a Velcro cuff. And in fever, you may not measure it. Like if a patient is a known case of hypertension and today has come for fever, I generally don't measure because that is going to be a wrong reading. But if I have signs of compromise, then I must check. This is also because the BP is maintained until very late in the process of cardiovascular shock, as children and adults both have good peripheral vasoconstriction. So what happens is, peripheral vasoconstriction happens, my CRT will rise, but my heart will have enough blood to pump across this body. What are signs of circulatory compromise? Increased capillary refill time, increased peripheral central temperature difference. This we find difficult to measure because we don't have rectal temperature very often. Skin color becomes pale. Altered level of consciousness. If one sign I have to keep in mind to pick up seriousness, I would say altered sensorium. Poor or absent peripheral pulses. A radial pulse is a peripheral pulse. Reduced urine output. Always inquire. If a patient of diarrhea, drinking water, not drinking water, ask how many times you have passed urine. For a child, the parents may say, we don't know, because in a diaper, it mixes with stool. I don't care. Don't put a diaper. I want to know whether urine is being passed or not. Because you may miss an early sign of severe dehydration. Neurological alertness, whether the patient is alert or not. A child who's your regular patient is brought to you with fever today. Every time the child comes with fever, the child is playful. Child holds your stethoscope, pulls at it, but today the child looks at you with a blank stare, turns the face away. This child is very critical. He may be having meningitis, encephalitis, or a severe sepsis. Is the person awake? Responds to verbal stimuli? Responds to painful stimuli? If you are not getting response to verbal stimuli, you have to ask for painful stimuli. The matter is already grave. And unresponsive, of course, is then nothing you can do. Then certain cells. A dictum is that fever of more than 24-hour duration, both adult and children at least get a CBC and routine urine done. RBCs carry oxygen to the tissues through hemoglobin. WBCs are part of immune system. Total leukocytosis, WBC high, about 20,000 can be sinister. Leukopenia below 500 in a patient could be sinister. Platelet thrombocytopenia less than 1 lakh, needs indoor patient indoor hospitalization less than 50,000, hospitalization is a must. Below 10 and 20,000 is worrying. Even if there's no bleeding, they need platelet transfusion. Body fluids. We only talk of dehydration, but have you wondered what is our body fluid? 45 to 50% of adult weight is water. So if you have 50 kilos, you have 25 liters of fluid in your body. Variations occur based on age, gender, and amount of body fat. 80% of a neonate is the water. That's why I said one large stool, one large vomit can kill. So this is some diagrammatic presentation, total body water. Out of the total body water, 63% is intracellular in the cells and 37% is outside the cell. And in this, we have plasma, we have lymph, we have transcellular fluid, and we have interstitial fluid. Now, if the water gets less, that is dehydration, and other things that we will see subsequently. These intracellular, extracellular fluid have various ions getting transported through the membranes. And this is the transport of electrolytes, mainly sodium, potassium, chloride in the body. So we have electrolytes, we have glucose, and we have pH of the fluid. What is the significance? Acute gastroenteritis, high fever, fulminant infection, you will have dehydration, you have electrolyte imbalance. Certain fevers like cerebral malaria will give hypoglycemia and will give hypoxia. Diabetic ketoacidosis, an uncontrolled diabetes with a simple viral fever can go into diabetic ketoacidosis, which is life-threatening. Electrolyte imbalance and metabolic acidosis, which I already mentioned. Then there are WBCs and there are platelets. Thrombocytopenia, low platelet, malaria, dengue, severe viral fever, cancer chemotherapy. Leukocytosis, acute infection, sepsis. We'll see what is sepsis, leukemia, or other myeloproliferative disorders. Leukopenia, cancer chemotherapy, fulminant infection. You have metabolic end products. Creatinine is an end product of muscles. Urea, they both indicate acute renal failure if the rates have gone up. Ketones in urine will show diabetic ketoacidosis, or in a non-diabetic will indicate that the patient is in starvation. Patient in starvation, fever with ketone bodies 2+ needs IV fluids. And if ammonia is raised, it is called hepatic encephalopathy in a chronic liver disease patient. Sepsis. Sepsis is a dreadful word. Bacterial infections can lead to sepsis, more likely in immunocompromised individuals. Pneumonia, urinary tract infection, meningitis, leptospirosis, which is a bacterial infection. Serious medical condition characterized by a whole body inflammatory state. The whole body is in inflammation. In layman language, this is infection of the blood. The body may develop this inflammatory response to microbes in blood. So what will it present with? The original infection symptoms will be there, plus there will be very high fever and high WBC. All sepsis needs hospitalization and may be in ICU. Sepsis can lead to septic shock, multi-organ dysfunction syndrome, and death, even with immediate and aggressive treatment. So if your patient is going in sepsis, do not delay in diagnosis. What is the example of end organ dysfunction? I already told you 5 target organs. So let's not waste time on that. So these are the 5 organs. Once again, if more than 2 get affected, it is called multi-organ dysfunction syndrome, and 99% it leads to death. Coming to specific infection. So summarizing what I spoke till now, every fever patient, beside temperature, you have to keep a watch on pulse. In a child, capillary refill time, BP in an adult, oxygen saturation, circulation, chest retraction, and neurological status. Ask the patient casual questions. What is the date? Since when you have fever, 3 days, what date was that? Whether the patient remembers. Dengue syndrome is a self-limiting viral disease, requires no treatment, just support. Platelet should not drop. Patient shouldn't go in dehydration. There are 3 types: classical dengue, dengue hemorrhagic fever, and dengue shock syndrome. In hemorrhagic fever, there is bleeding. Shock syndrome, the heart cannot pump enough. It requires inotrope medication. The last 2 require ICU hospitalization. Again, repeating GOI guidelines. Sorry, this is repeating slide again. How do people suffer or die? Low platelets. Sepsis, acute respiratory distress syndrome, and ARF. It's not only COVID that gives ARDS. Even a dengue, or I have seen even in Vivex malaria, they get ARDS. Bleeding, uncontrolled bleeding. Commonest is from the nose, gums, urinary tract. But then if there's a bleeding in the stomach or in the brain, that could be fatal. Dengue also affects liver, so dengue hepatitis. One small point when I say that in dengue, whenever you ask for dengue blood report, don't ask for NS1 only. Ask for IgG, IgM also. Now tell me, if you have a patient today who's got fever last 2 days, but IgM and IgG both are positive, this indicates is a secondary infection. This patient is more at the risk of dengue hemorrhagic fever, dengue shock syndrome. Never ask for one, ask for both. Complications, fever or recent history of fever lasting 2 to 7 days. Any hemorrhagic manifestation. Anywhere, bleeding from nose, but doctor, I blew my nose. Doesn't matter, you have dengue. I will take it as a bleeding manifestation. The most common bleeding manifestations are mild and include a positive tourniquet test. If your patient of dengue has platelets below 1 lakh, apply a tourniquet, inflate above systolic blood pressure, hold it for 3 minutes and deflate the cuff. You will see tiny petechial hemorrhages. That is, tourniquet is positive. Patient better be in the hospital. Petechiae, hematomas, epistaxis, gum bleeding, and microscopic hematuria. More serious hemorrhage, intracerebral, vaginal bleeding, whether periods are due or not. Hematemesis and melena. Acute gastroenteritis, also called as food poisoning. Criticality or death may occur due to ingested toxins and dehydration, electrolyte imbalance. And when dehydration gets more, that leads to acute renal failure. What do I mean by ingested toxin? People who eat roadside food, pani puri, sev puri, at times they eat and they immediately vomit. That thing is so unhygienic that the bacteria have already formed toxin. and that can kill. Infants may succumb to one large vomit, one large diarrhea. I have mentioned 3 times already. So always keep in mind your patient is taking ORS, water, buttermilk. Keep asking that question. And the motions may have stopped. But if intake is not there, that child or adult needs to be in the hospital. Criticality in malaria, largely falciparum. They can develop cerebral malaria, which will present as fever and seizures. Severe anemia, because malarial parasites reside in RBCs, and RBCs rupture to release parasites in bloodstream. They get severe anemia. And black water fever, dark urine, it is acute renal failure of malaria. But nowadays, we have seen in Plasmodium vivax also, low platelets. I have seen in my practice ARDS and ARF. Rarely they get sepsis because it's not a bacterial infection. Which patient should be admitted? Poor general condition, toxic, dehydrated patient. Complicated malaria, we have mentioned already, cerebral malaria, acute renal failure, dyspnea, oxygen below 92%, bleeding, uncontrolled vomiting. This is a very important point. Parasitemia about 2%. What is the meaning of this? Good labs will give you this report. Malarial parasites reside within RBCs. This tells you that more than 2% RBCs are infected with malarial parasites. Just imagine the number of RBCs, we have trillions. A 2% parasitemia, even a government hospital admits without you giving a note. Hypotension, BP below 90/60, jaundice, and platelet below 50, even if the condition is stable. Influenza, including H1N1 influenza. So viral infection, everybody says we got flu, we got influenza. That doesn't require to be worried. But if you have a specific influenza where the patient is getting respiratory distress, patient is getting hypoxia, and fever is not going, this patient you need to be worried about. Every patient diagnosed of H1N1 or now H1N2 does not need hospitalization. Hypoxia, respiratory distress, only 2 things. However, in the very young, elderly, and those with other serious medical condition, infection can lead to severe complications and maybe death. Age, young children, older adults are more at risk. Living conditions, overcrowding. Immunocompromised status, I have said, long-term oral steroids, chemotherapy, HIV, diabetes, chronic renal failure, CLD, COPD, asthma, interstitial lung disease, and tuberculosis. Asthma, obesity, above BMI above 40 are more at risk. Look for respiratory distress. Recession of intercostal spaces, hypoxia, and respiratory rate. Chikungunya. Warning signs. Chikungunya has no specific treatment. The treatment is long drawn. The pain takes 2 to 3 weeks to go. But extremes of age, patient below 1 year and above 60. Pregnancy. Fever persisting for more than 5 days, high fever 102 and above. Uncontrolled vomiting. Intractable pain. They have so much pain, they can't tell you where the pain is. Oliguria, anuria, that means the chikungunya virus has affected the kidneys. Postural dizziness, cold extremities, refractory hypotension. Normally, a BP is low in standing, may become near normal in lying down, or give intravenous fluids or oral rehydrating solution, but the BP doesn't rise. Bleeding disorders. Although all these in chikungunya is less than 1%, but that 1% should not happen in your patient. Altered sensorium, everywhere I said altered sensorium, altered sensorium. And altered sensorium in chikungunya indicate there is meningoencephalitis. Leptospirosis occurs when the stagnant dirty water gets infected with rat's urine and people wade into this. Everybody has microcuts in the feet and these bacteria enter. Severe leptospirosis, acute respiratory distress syndrome, oxygen below 80 requiring a ventilator, low platelets below 50, renal failure, renal output is virtually nil, multi-organ dysfunction syndrome, lungs are gone, kidney is gone, heart is not able to pump. Whale syndrome is a second name given to severe leptospirosis. Profound jaundice, bilirubin above 10-12, creatinine raised, renal dysfunction, hepatic necrosis, acute hepatic necrosis. Hepatic necrosis is generally fatal. Pulmonary dysfunction, lungs cannot oxygenate, you need ventilator. And bleeding from everywhere. These are the warning signs: hemoptysis, platelet count below 1 lakh or 50,000, total bilirubin about 2.5, WBC above 13,000, hematocrit below 30, that means that's anemia, and respiratory distress. Any of these, you need to admit the patient. Which patients are likely to die? Respiratory failure, RR about 24. Hemoptysis, that means lungs are affected badly. Oliguria, kidneys are also affected. Metabolic acidosis or serum bicarbonate below 20 millimole per liter. Platelets below 1 lakh, but ideally below 50. Coming to pneumonia. What is pneumonia? The upper picture is a normal alveolus, and lower picture, if you see, these alveoli are lined with pus. It's consolidation. Inflammatory illness of the lung, alveolar inflammation, and abnormal alveolar filling with fluids. Pneumonia results from a variety of causes, including infection with viruses, bacteria, fungi. Fungal pneumonia occurs only in immunocompromised person and is a very life-threatening condition. Or chemical and physical injury. You all must have heard of the condition called aspiration pneumonia. I'll explain that. Warning signs: fungal pneumonia. Any systemic fungal infection, not topical, is a serious condition. Severe pneumonia, large surface area of lungs affected, 2 lobes, infants, elderly, plus minus immunocompromised. Hospital acquired pneumonia, patients get admitted for gastroenteritis. In the hospital, they get pneumonia. That pneumonia is more critical than community acquired pneumonia. Serious comorbid illness. As I said, this patient of mine, uncontrolled diabetes, gets dengue and now has bilateral pneumonia. Multilobar lung involvement on X-ray chest. Typhoid fever. Very rarely, typhoid also kills by affecting the meninges or perforation of the gut. Acute abdomen, perforation of intestinal ulcer. I sure everybody knows typhoid is ulceration in the small intestine. Severe pain in abdomen. Typhoid usually does not present with severe pain. It presents with a tumid abdomen. Uncontrolled vomiting. Continued high fever beyond 5 days after diagnosis and initiation of treatment. If 5 days fever does not go, that's a warning sign. Meningitis, encephalitis. meningeal triad, a triad of fever, vomiting, and headache. Other things that may be photophobia, patient does not want light. Phonophobia, patient does not want to hear sound, is very important. Need hospitalization to prevent neurological morbidity and permanent damage. Every doctor should learn to check neck stiffness in a child. When it comes to meningitis, I must tell you, you refer 100 patients for admission, 99 are not meningitis. One is meningitis. 99 wrong referrals are permitted if you can save that one child or one adult. Acute otitis media, boil in and around nose. Why that can lead to meningitis? Think of the anatomy. The inner ear is 2 to 3 centimeters away from brain and meninges with a very thin layer of bone, base of skull. Similarly, nose also. So these infections reach meninges fast. Always in a crying child with fever, put a good source of light and rule out acute otitis media. Don't just think it is viral. Rule out acute otitis media. Encephalitis, fever with altered sensorium. You may not have vomiting here. Need hospitalization to prevent neurological morbidity. Both meningitis and encephalitis need hospitalization. Now, Dr. Keyur Vakharia requested me to talk on Chandipura virus. I have not seen any case, so I did some research. It is now prevalent in Gujarat. Some 15-20 cases have been identified. In extreme cases, the viral infection can prompt coma and death. As indicated by a report by scientists studying the virus, primary cause of death for most contaminated patients or infected patient is encephalitis, inflammation of active brain tissue. So if you are in Gujarat, if in your area there is Chandipura virus, make sure for every fever you are asking the history of altered sensorium. The virus was first discovered in 65 and was named after Chandipura village of Maharashtra. The virus is said to belong to Rhabdoviridae family, which is the same virus as rabies virus. Accompanied by unexpected beginning of flu-like symptoms. So they may look like flu, but always high fever, seizures, diarrhea, vomiting, convulsion, and altered sensorium. Altered sensorium is always a grave sign in fever. Extreme cases, coma and death. High fever or even low fever in immune compromised conditions with neurological features. Commonest is altered sensorium. In an alert, don't think of changing remedy, refer. Acute UTI. Commonest cause of acute urinary tract infection is E. coli, which is a gram-negative bacteria, and gram-negative bacteria cause gram-negative sepsis very fast. So UTI is the commonest infection to give sepsis. Second is pneumonia. More common in women because the urethra is smaller and less hygiene. Very common in diabetics and those with obstructive uropathy. What is obstructive uropathy? I have a patient with 6 stones in the kidney and ureter, but no hydronephrosis, no hydroureter. These stones are not obstructing the passage of urine. They cannot be cause of infection. But if I have slight hydronephrosis or hydroureter, that is an obstructed calculus that will cause infection. Sign symptoms, acute onset high fever, 102 to 104 with chills. How do you differentiate clinically malaria with UTI. Malaria will give you chills before fever. UTI will give you chills after fever. Dysuria, burning, increased frequency. In immunocompromised patient, risk of sepsis and acute renal failure. What is important? Routine urine examination. Pus cells present should be more than 50 per high power field. If urine shows RBCs 100 plus per high power field and pus cells 25 to 30 per high power field, that is not infection. That is hematuria for some other cause. Ask for a culture in a recurrent case or a severe case. Colony count higher than 1 lakh is significant for non-diabetics. So I have a non-diabetic with a colony count of 60,000. That is not urinary tract infection. Many labs do not give colony count even in culture. You should insist on it. In diabetics, any colony count needs to be treated. Ultrasound abdomen, CT abdomen, pelvis, wanted to see whether there is an obstructive uropathy. And then many cases of urinary tract infection affect the kidney by the infection ascending through the ureter. Urine infection traveling to kidney tissue, again a condition that requires IV treatment in the hospital. Ultrasound CT diagnosis. Treatment, I am telling you what we give. I am not telling you all to give antibiotics. Culture-based, broad spectrum, long-term IV antibiotics, 10 to 15 days, needs hospitalization. Even if you are treating by homeopathy, talk to a consultant, admit, and you may continue your own treatment also. Then cystitis. So we got urinary tract infection. We got inflammation of the kidney. Now comes the bladder. The bladder wall is inflamed. Infection of the urinary bladder. It's an ultrasound diagnosis. You can't diagnose basis urine report. Here you will see that bladder wall is thickened and the bladder shows floating debris. Long-term antibiotics, initially IV, then oral. And that, friends, brings me to the end of my talk. There are 2 minutes left. I have been little fast, but had to be done. Thank you very much for your hearing. Are there questions, Dr. Nirupama?
No, not yet. Just waiting if anything comes.
Somebody said send PDF on Telegram group.
Everyone is saying excellent session, excellent. There are no queries as such. If you have any queries, please write down. Till then, as you all know, our e-journals, you download it and you can join our WhatsApp group, our Telegram group, where you'll get all the information. There is one question. Please tell why IgM and IgG both to be done in dengue.
Okay, there is a question by Dr. Chanda Shah.
Yes,
Please
IgG.
tell again why IgM, IgG both to be done in dengue.
Yes.
Okay, ma'am. As there are 3 tests to be done in dengue serology. One is NS1. NS1 is an antigen. It tells you that the body is exposed to dengue. IgM tells you that dengue is established. That is the current infection. IgG tells you that there has been a past infection also. Now that past infection was 10 days back, 20 days back, a month back, a year back, a decade back, we cannot say. But the second infection of dengue with IgG positive, IgM positive indicate that this patient has higher chances of going into complications like dengue hemorrhagic fever or dengue shock syndrome. So that is why IgM, IgG both are required.
There is one question by Dr. Kayur. Hypotension is nowadays
The reason
frequently
for chronic
noticed.
cystitis. The reason for chronic cystitis is not proper treatment given in the first shot. Because see, from our line of treatment, we do antibiotics for long period, but when you are treating, you will be reluctant to ask the patient to do a sonography again after 4 weeks or 6 weeks, and then the chronic cystitis becomes chronic cystitis. Chikungunya, what should be prescribed for persistent arthralgia lasting for months? I can only give, since I am an allopath, I can only say that if painkillers, NSAIDs don't work, we at times give HCQ, hydroxychloroquine, which is a drug for autoimmune diseases. Clinically, you can't diagnose chikungunya. You have to do chikungunya IgM. Dr. Aarti Mehta, what test do you ask for malaria? We should ask for smear and antigen both. But if your symptoms are classical, which nowadays we don't get, I would suggest you start treatment. Diagnostic criteria for leptospirosis, again IgM leptospira. Hypotension is nowadays frequently noticed in viral illnesses. Why so? Because as a practicing doctor, we do not ask how much water is being consumed. I'll tell you a normal conversation that goes through. Do you drink water? Yes, I drink water. I didn't ask, do you drink or do you not drink? Do you drink 2 liter plus water? My question was, how much water do you drink? Oh, I drink lots. And no doctor has time to waste for 3 questions to ask the quantity of water. So if you are sure that intake is proper, 2 liter for an adult with a normal kidney with fever should go to 2.5 to 3 liters. If that is being consumed, that hypotension should be taken as a sinister sign. If the patient is not affording, how can we do minimal tests and come to diagnosis? See, Dr. Jigisha, first I will do a CBC and a urine because I'm worried of sepsis, especially non-affording patients. If urine is normal and CBC is normal, I ask a very simple question. Every patient says, I have a body ache. I ask for hydration status. Then I ask this question in whichever language, whatever the educational status of a patient. I have a scale of 1 to 10. 10 is the worst pain you have experienced. At what level is your pain? Patient says 7, 8. I ask for dengue test. Patient says 3, 4. I wait. I observe. So you have to be a clinician and ask for only rational investigation. You cannot just ask for a fever profile because a fever profile done early will come negative. People get fever in the night, 10 o'clock, 7 o'clock, they go in the morning, do dengue profile and come with the reports all normal. Third day, they come up with IgM positive. Clinically differentiate chikungunya and dengue. A very slight difference. Dengue has extreme body ache, extreme headache. Chikungunya pains are more around the joints, whether it is spinal joints or it is the limb joints. But that is all. How long it takes chikungunya IgM to be positive? It takes time. So first 10 days to at least don't do. Similarly, leptospira also. Diagnostic criteria, I told you, doctor, this thing. Pus cell in urine more than 120. E. coli sensitivity to nitrofurantoin. How many days antibiotic to be given? See, the pus cells will come to normal with 5 days also. But you check urine after stopping, 2 days after stopping. And if the pus cells have reappeared, then you have to give for longer. At least 10 to 14 days you should give. Male 12, fevers in 7 days, severe headache, nausea, vomiting. CBC normal, dengue negative, Vidal negative, SGPT normal, MP negative. Clinically, have you checked for neck stiffness? If there's no meningitis, treat as severe viral and make sure hydration is enough. And when you say dengue negative, IgM, IgG all negative.
Do we
Zika,
look
I
for
have
Zika?
not yet started looking because we are not getting so many cases, at least in Bombay. Typhoid blood culture mandatory to confirm is rather difficult to do in every patient. But Vidal test is something which should not be done. You should insist on IgM. IgM typhi. Don't do Vidal test. NS1, you can wait for 48 hours and then do. Do not do immediately. Which book should we read for commanding a blood investigation? Dr. Sadhvi, wait for a few months. We are launching an e-book. Which, when is post-vaccination fever to be taken seriously? First, you see which vaccine it was, whether that vaccine gives fever. Nowadays, even polio triple, the DTP which has come, the DTaP, does not give fever. So if you have a injection site swelling, redness, that injection was not given properly, that may give fever. But nowadays, vaccines don't give fever. So don't take vaccination fever seriously. Rather, take post-vaccination fever seriously. Thank you very much for the amazing interaction. Wish to see you in 6 months again when you all need some clinical topic. Thank you, Dr.
Thank you,
Nirupama.
sir. Thank you, sir, for a wonderful session. And I hope from tomorrow, all the clinicians will be very alert in their
Okay,
clinic.
there's a question.
Thank you.
In a child, after how much time investigation in a case of fever, what is the right time to get investigation done? In a child, I will say 24 hours of documented fever of 100 plus. CBC urine should be done. But, documented fever. My child has fever for 3 days. Have you checked fever? No, I just feel it warm. He's very warm, doctor. No, I want thermometer reading. With a
Whether
dengue
dengue
can
can
present as
present.
acute diarrhea, vomiting, fever since first day. Yes, any virus can present in any way. And dengue anyway has 4 viruses, 4 subtypes. Nowadays, I'm getting, at least in last 2 weeks, viral diarrhea have come up so much that 10 to 15 motions a day in children. And then if you monitor body weight, they're not losing weight at all. Thank you again. I'll take your leave now.
Thank you, sir. Thank you for wonderful session. Thank you, friends. We'll meet again in third Friday of next month. Thank you.